Channel. In this video I will discuss chronic myeloid leukemia. As the name indicates that there is uncontrolled proliferation of the myeloid cells. Myeloid cells, for example, neutrophils, eosinophils and basophils. So these cells are increased in number. It is typically associated with Philadelphia chromosome, that is T922 translocation, leading to formation of this BCR-ABL1 fusion gene. And when this fusion gene is formed, it has tyrosine kinase activity. Tyrosine kinase activity, and it leads to increased proliferation of the myeloid series. So it accounts for almost 15% of total adult leukemias, and median age at presentation is 55 years. 55 years. So 55 years is the median age at presentation. Slight male predominance is also seen. So I have told you that the main cause is BCR-ABL1 fusion gene, and it leads to increase in the tyrosine kinase activity. And when there is increase in this tyrosine kinase activity, it leads to uncontrolled proliferation and reduced apoptosis, leading to increase in the myeloid series. So patient may be asymptomatic initially during the chronic phase because the cells can function normally and can be detected on routine CBC. The symptoms that patient present with are fatigue due to anemia, weight loss because this is a hypermetabolic state, night sweats, hypermetabolic state, and splenomegaly. Splenomegaly is actually may be massive and lead to early satiety and abdominal pain. And there is abdominal fullness due to this splenomegaly. On examination, you will see that there is splenomegaly, maybe there is hepatomegaly. The patient is pale, and due to thrombocytopenia in late stages, there is bruising. What are the phases of CML? It is having two phases. Chronic phase, more than 90% of the cases are diagnosed in this chronic phase, and it is indolent and it is responsive to therapy, that is imatinib. Imatinib is given for this chronic phase, and actually imatinib is a tyrosine kinase inhibitor. Then second phase is accelerated phase. In accelerated phase, the blasts are starting to increase in number and cytopenias are worsening, that is anemia and thrombocytopenia, and it is resistant to therapy. Next one is blast crisis. As the name indicates that there is increase in the blasts equal to or more than 20% blasts in the blood and bone marrow, and therefore when there is increase in the blast number equal to or more than 20% in the bone marrow, it leads to development of acute myeloid leukemia. It clinically resembles acute myeloid leukemia. Diagnosis: CBC. On CBC, you will see leukocytosis, basophilia, and thrombocytosis, and WBC counts may be more than 1 lakh up to 5 lakh per MCL. So a lot of increase in the number of WBCs. Peripheral smear shows myeloid cells in all stages of maturation. So myeloid cells are seen, but these are mature cells. And bone marrow biopsy shows hypercellular bone marrow with granulocytic proliferation. After these investigations, you should go for cytogenetics. And as I have told you that there is Philadelphia chromosome leading to T922 translocation, BCR-ABL fusion leading to increase in tyrosine kinase activity and increase in proliferation and decrease in apoptosis. Treatment is first line is tyrosine kinase inhibitors. Imatinib is mostly given 400 mg per day, and imatinib is responsible for actually controlling the disease in almost more than 90% of the cases. And for checking the response to imatinib, we should do PCR. For BCR ABL transcripts, and their quantity should be reduced with the use of this imatinib. If imatinib doesn't work, then we should go for second generation tyrosine kinase inhibitors. These are dasatinib and nilotinib, and another one is bozotinib. So these are second generation and are used when this imatinib doesn't work. That is, BCR ABL levels do not fall, then we use these second generation agents. And if these second generation agents don't work, then we can go for third generation agent, that is positinib. Then if all these agents don't work and if there is conversion to blast phase, then we can go for hematopoietic stem cell transplantation. Monitoring can be done of the disease activity and for the treatment response by BCR ABL transcript levels by PCR, as I have told you. Prognosis. Actually, there is tyrosine kinase inhibitor therapy that has actually excellent responses to CML, and therefore life expectancy in chronic phase of CML is almost near normal. And if there is progression to blast crisis, then it leads to poor prognosis. So this is all about chronic myeloid leukemia.